So in the last class, we were discussing about anal canal. So it starts at pelvic diaphragm and ends at the anal verge. So there is an anorectal ring, consists of puborectalis muscle, external sphincter, longitudinal muscle that continues into the rectum, from rectum to the anal canal, and the internal sphincter. So, as you know, the internal sphincter is involuntary, whereas external sphincter is voluntary muscle. So these are the various components: the puborectalis, the external sphincter, the longitudinal muscle, and the internal sphincter. So the epithelium also changes colors from rectum, which is pink, to red color in the upper part of the anal canal, where there are columns of Morgagni. So gradually it will assume plum color at the bottom of these columns, in between which there are crypts of Morgagni, into which the anal glands that are present in between the two sphincters. So here, this is the place for anal glands. They will open. Then you have got below that is the anal skin that is devoid of any hair follicles or any pigment. That's why it is parchment color. Whereas true anal skin is below that. So the whole thing is about 4 centimeters. And here there is an important line called as dentate line. So at this dentate line, the hindgut and the proctodium will meet. So this is columnar epithelium, this is cuboidal epithelium, whereas this is stratified squamous epithelium. Now, anal examination is you need good light. Patient should be relaxed. He should be explained well about the procedure, and particularly in females, you need a private environment with a female attendant also. So these are the various positions: Sims position, knee elbow position, lithotomy position, mainly used for surgery. Whereas these two for female Sims and for males knee elbow position. So there are 3 parts, that is inspection, wherein you can see all the perianal conditions, whereas finger digital examination, where you can feel induration, tenderness, masses sometimes, but not piles. Then proctoscopy, you will introduce proctoscope and then you can see all these lesions. And at times you may need to do sigmoidoscopy to rule out the other conditions, particularly carcinoma. So coming to the congenital abnormalities, anorectal malformation. So mainly because of the fusion defects between hindgut and the proctodium. So it is divided as high and low depending upon the termination of the rectum. Is it above pelvic floor or below pelvic floor? If it is above, means high, complex. Whereas if it is below, it is low and it is simple. So low defects are covered anus, anal membrane, whereas high defects are having other problems also. So there are also the males, it is rectobulbar, whereas in females it is rectovestibular. So suppose there is meconium in the urine, means it is high and then there is having a connection with the urinary tract. So you should also evaluate for water or bacterial anomalies and wait for 24 hours so that the distal limit you will find out on invertogram. So this is rectobulbar, this is rectovestibular. So this is low defect where the air is almost at the tip, whereas high defect it is stopping short here. So for low defect it is simple anaplasty, whereas for high defects it is colostomy followed by PSARP, that is posterior sagittal anorectoplasty. So there is another lesion that is called as post-anal dermoid, like any other dermoid, but the problem is it may be hidden in the hollow of the sacrum, so the patient may experience difficulty on defecation. So it need to be removed completely and blocked with coccyx, particularly in children, because there is a problem, that is sacrococcygeal teratoma can be a complication. So pylonidal sinus also we have discussed, which is usually one non-infected midline opening will be there at the natal cleft over the coccyx. So it is not a fistula because it is not lined by epithelium, lined by granulation. It's commonly called as jeep disease because these military people who travel in jeeps is fairly common. So pylonidal sinus can also be seen interdigitally, hands, particularly in hairdressers, and in the axilla and umbilicus in hairy men. So age is between 20 to 29, and you can see in men mainly, and so there may be pain and swelling because of infection. So repeated abscesses may be there. It has to be drained through longitudinal incision, but away from the midline. That is very, very important. So once you open, you can treat it like a fistula, either keep it open, sinusotomy, or close it after excising the all tracts. So closure, you should avoid midline wound, that is very important. So many procedures are there like limber, Z-plasty, Caridakis, and Bascoms. We follow Bascoms where we will give a para-median incision and then remove all the necrotic and debris material, granulation tissue, clean it, and then of course we will remove this, but there should be no connection between this and this. That is important. And finally we will close it, paramedia. So today we will discuss about fissure in anode. So it is nothing but a longitudinal split of distal anal canal. So it will not extend beyond dentate line. That is another important. If it is extending beyond, means it is something else, not fissure in anode. Some disease that is having a specific etiology like Crohn's disease. Not only that, if it is not in the anterior or posterior aspect, anteriorly or posteriorly in the midline, it is something else, means you have to search for specific etiology. So usually posterior midline is commonest. In men it is 99%, whereas in female it is 90% posterior midline. So that means both in males and females, posterior midline is commonest. Whereas anterior may be there, particularly in women, about 10% following vaginal delivery because of the injury during childbirth. So as I told you, you have to search for specific etiology also. Very important. Don't dub it every case as fissure in anode. So what are the causes? It is mainly trauma caused by evacuation of hard stool. Particularly, patients will be complaining in winter because they are not thirsty in winter. They will take less water. And females, particularly, they don't have a convenient place for going to this restroom. So they will also postpone their evacuation, and thereby there is hard stool. That is the reason for this longitudinal split. Of course, there is associated anal hypertonicity, sphincter tonicity is more, and there may be to some extent because midline is less vascular. That is also another reason. So the split that occurs is not healing. So that is the reason for fissure in anal. So this is the anal canal, and then you can see that posteriorly it is so fissure extended. So this is the posterior fissure in anal. So usually it is young adults, as I told you, between 20 to 30, and there is pain on defecation. Otherwise, is okay, he or she. But during defecation, in fact, they may postpone defecation for fear of pain. That will lead to further hardening of the stools and further breaking of this. So passage of fresh blood is another one. So streak like blood may be there. And of course, the cause and symptom are constipation. So if it is becoming chronic, then there may be a sentinel tag along with this in the posterior aspect of the fissure. There may be itching and discharge of mucus also. So you have to exclude important conditions like Crohn's, tuberculosis, particularly very, very important, and STDs, HIV, cytomegalovirus, and rarely Kaposi sarcoma, squamous cell carcinoma, and lymphoma also. So, as I told you earlier, patient may not cooperate for examination. That's why examination under anesthesia is important. So most of these need conservative management. That means if the stool is semi-solid, then the problem is over. So you add more fiber and bulk also. So that will lead to more stools, more liquid stools, so that patient can pass easily. And stool softeners also. So both fiber and stool softeners, laxative. So both combinations are there, fiber and stool softener combinations are available. You can prescribe. Most important is increased water intake. Though the patient is not thirsty, they have to take water plenty so that stools become a bit semi-solid, if not watery. Then warm baths will also aid in healing. So specific treatment is you need to relax the internal sphincter which is in spastic condition. So glyceride trinitrate, that is 0.2%, or diltiazem, which will relax. So diltiazem you must be knowing in cardiology, they use it extensively. So 2%. The only problem with this is a headache. So vascular dilatation will be there along with relaxation. So some part of it is getting absorbed, and then it will produce vascular dilatation, and then There may be headache also. So 2 to 3 days there will be applicator also, so that not only in the margin, even inside also they can apply, so that the tone will be a bit lessened. Another thing is to decrease the pain, you can also prescribe local anesthetic jelly like xylocaine jelly. So xylocaine jelly is available in 2%, whereas ointment is available in 5%. So both can be for immediate use 2% jelly, whereas for chronic cases you can use ointment. And some people inject Botox in that region, so it can be repeated. So this is the conservative treatment. Whereas some people where conservative measures fail, particularly in men, young men who are having a spastic internal sphincter, what you can do is controlled stretching, that is stretching of the anal canal, also called as anal dilatation, Lord's anal dilatation. So Lord's anal dilatation. Where else you heard this name, Lord, that is, where else you have heard this name? Can anybody tell me? Not heard Lord's. Yes. Hydrocele. Good. 14. So what is the, in what aspect of hydrocele? Is it clinically there is a sign, or is it investigation, or what is this? Hydrocele, you are correct, but in relation to hydrocele, what? Operation, good, very good. So it is called as Lord's plication. Yeah, 4-8, you are also correct. Lord's plication. Okay, so that is also Lord's, and this is also Lord's anal dilatation. Previously we used to follow this, but excessive stretching will lead to multiple breaking of the central sphincter. Thereby, the patient may suffer with incontinence. So that's why we stopped this procedure unless you suspect a sphincter spasm. So nowadays what we do is lateral anal sphincterotomy, that is on the left side. So we will cut the internal sphincter fibers so that the sphincter spasm will be decreased. So we will not cut the entire internal sphincter, only lower parts of the internal sphincter we will cut. So that is can be done either by open or closed methods under regional, that is spinal anesthesia or general anesthesia. If the sphincter tone is normal, if you do sphincterotomy, what will happen? There may be incontinence. So in those cases, what we do is advancement flap. Anal advancement flap is, but if you remember this local conservative treatment, particularly with the GTN 0.2% or diltiazem 2%, or xylocaine ointment, fiber, stool softeners, and surgery, lateral sphincterotomy, that's more than enough. Then we have another condition called as proctalgia fugax. This is not for academic interest. It is mainly practically you may be seeing patients complaining of severe attacks of severe pain in the rectum. Suddenly the pain will come and it will last few minutes and disappears. Just like it has come, it will disappear. So spontaneous, without you doing or the patient doing anything, it will just disappear. So it will also be recurrent problem. Like you might have heard about trigeminal neuralgia. But this is not connected with nerves. It's mainly maybe a segmental cramp of the pubococcygeus muscle. So this is particularly seen in anxious people, those who are in tension, so stress, those people may experience proctalgia fugax. So the only thing is relaxing techniques, biofeedbacks, all these things are there. But simply the treatment is not very much satisfactory, but you can try various methods like for tension and neurosis you may give amitriptyline also, and local Botox also is the treatment, and some people might be doing this puborectalis, they may be cutting it, but it will result in incontinence. So mainly conservative, proctalgia fugax. Then we'll go to all important topic, that is hemorrhoids, or common name is piles. So in Greek, hema means you all must be knowing, it is blood, and rous means flowing. So blood flowing means bleeding. So hemorrhoids, the commonest symptom is bleeding per rectum. That's why the name hemorrhoids, hema rous. Then in Latin also we call it as a pile, that is pile mass, a ball. Pila means a ball. So I told you that there are anal cushions at 3, 7, 11 o'clock positions, and these anal cushions normally asymptomatic, they have become symptomatic. They have even become a bit masses. So what are hemorrhoids means? They are symptomatic anal cushions. So though I said 3, 7, 11 o'clock positions, in between also there may be secondary position. They are not secondary piles, mind you. So this is 12 o'clock position, this is 6 o'clock position, this is 3 o'clock, this is 9 o'clock. That means this is left side. Okay, so examining like this, the lying patient. So So 3 o'clock, 7 o'clock and 11 o'clock. But in between, these are the positions. Whereas in between there may be pile masses. So they are called as accessory. So secondary position, but they are not secondary piles. Please remember. Of course, piles means they are mainly internal, because in these positions, these anal cushions with associated vessels, both arteries and veins, mainly venous congestion is there. So external hemorrhoids are not true piles. They are different. So piles means they are internal only. There may be, of course, internal-external, when the internal hemorrhoids are extending onto the external position also. So suppose this is dentate line. The pile mass will start here. It may become like this, and then this is externo-internal, whereas this is internal. So it is only extension of internal pile, externo-internal, not external pile. External piles means there may be a mass, but it is nothing to do with venous fluxes. Okay, hope I'm clear. Then what are secondary internal hemorrhoids? Secondary piles. Secondary due to some cause. So that's why in the beginning I told you, if you don't put your finger in the rectum, you may put your foot in it. That's why, because you may be simply seeing the piles or the internal piles and then operating that patient will be a blunder if there is a coexisting anorectal carcinoma or there is portal hypertension. So the various sites of portal hypertension in the exam they may ask you. So the other sites, as you know, is in the esophagogastric junction. So that is important along with this internal piles. So if you treat only piles, it's you are harming more because there will be a lot of hemorrhage also because of the increased portal hypertension. Then increased intra-abdominal pressure also can lead to piles, ascites, mass abdomen. So similarly, gravid uterus, fibroid uterus, carcinoma of the uterus, cervix, ovary, bladder, all these conditions, even neurological conditions can lead to relaxation of the venous fluxes and then there is pile mass. So before dubbing it as internal piles, you have to exclude all these conditions by examining the patient as a whole, not tubular vision. Okay, so you have to exclude all these conditions before dubbing it as piles, right? So then what is the cause? So previously people used to think that it is actually the penalty the human being is paying for his standing position. Because he is standing, the piles are getting enlarged. That is, the anal cushions are getting enlarged. That was they used to think. Along with it, there is also a theory that because the portal veins are without valves. As you know, in varicose veins, it is piles is something similar to varicose veins. So in varicose veins, you know that the venous valves are becoming incompetent. So here there are no valves at all in the this portal vasculature. So that they used to think is the cause, or because of the increased tonicity of the sphincters. So all these theories are there, and constipation is another cause. So they are all unproved, most of them. Now what they believe is it is because of the shearing forces on the anus. So they will lead to caudal displacement of anal cushions. That's what I have shown you in the diagram. The anal cushions which are at the dentate line are coming down and manifesting as internal piles. Not only that, what will happen with aging is the supporting structures are fragmented. So there is elasticity of the anal cushions is lost. So they are kept in position by this elastic nature of the supporting structures there. But as the person ages, they are lost, and the loss of elasticity will lead it to this laxity, and then they will be dropping down the pile mass. So usually, though they drop down after, mainly during defecation, they may come down, but after defecation they have to go up, but they no longer retract. This is another problem. And there is increased abdominal pressure, particularly obesity, constipation, pregnancy. These are all the associated risk factors. So obesity, constipation, pregnancy, and aging. These are all the associated features that will be leading to finally to this caudal displacement of anal cushions. Okay. So the leading cause, the etiology, is the shearing forces. Okay. Now, what are the clinical features? Bleeding. In carcinoma rectum also, I told you bleeding. Here also bleeding. So bleeding per annum, you cannot take it lightly. It is a symptom of serious conditions like carcinoma and common conditions like hemorrhoids. So bleeding is principal and earliest symptom. In carcinoma rectum also earliest is so bleeding only. But yesterday in the exam I have seen most of you putting, in spite of my telling in the class, the earliest symptom is change in bowel habit. So that's why I thought it is better to discuss all those questions which we have asked in tomorrow's, after the seminar is over. We will discuss this MCQ so that some blunders you have committed yesterday, which can be, you can again learn some new points, and some blunders which you have committed, you can correct yourself. So bleeding, bleeding, bleeding. Always remember bleeding. Okay. So how it appears? It is separate from motion. That is important. So the pan, it will be a fresh splash because of the pressure over the pile mass by this evacuating stool. It will rupture, and then it will produce fresh splash in the pan. So this is the description they give for bleeding piles. Okay. If the bleeding is prolonged and chronic, what will happen is the patient, particularly in females, I have seen, they are presenting as anemia, not as piles. Okay. So pain, if there is pain, means think of some other diagnosis other than piles. Usually in the last stages only there is pain in hemorrhoids. But if the patient complains more of pain rather than bleeding, you think of other diagnosis. Okay. Then there may be itching, there may be mucus discharge, and ultimately in later stages the piles may prolapse, prolapsed piles or prolapsed hemorrhoids. This is the last stage of hemorrhoids. So these symptoms are very important. So I will again repeat, bleeding, principal and earliest symptom. It is separate from motion. So then it may cause even anemia. Pain, if it is there, means it may be some other diagnosis along with piles, itching, mucus discharge, and prolapse final. So these are the symptoms, right? So now the classification or degrees of hemorrhoids. First degree means they are only bleeding. So they are creating more noise rather than anything. They are very early stage, first degree, but they are bleeding. Second degree, in addition to bleeding, they will descend. The pile mass, patient will say while washing, so he or she is feeling some mass, but immediately it is returning back. So if it is returning, it is second grade. If it is not returning and the patient has to put it back, replace it back into the anal canal, that is third degree. Okay. If they are coming out and then not going inside, they are permanently outside, it is fourth degree. So these are the degrees. Only bleeding, first degree. Bleeding and mass, that is returning back, second degree. Bleeding mass, which has to be replaced manually, third degree. Bleeding and permanently outside, fourth degree. So these are the degrees of hemorrhoids. So what are the complications? So as I told you, sometimes there may be a profuse hemorrhage. Patient may come with bleeding continuously. So then if the piles are infected, I told you in liver class, portal pyemia, that means the portal vein will carry the infection into the liver. So portal pyemia. Then piles may be strangulated like this. They have come out, they are not going inside. So they are prolapsed and strangulated. So finally they may, after strangulation, they may have thrombosis. So this is thrombosed pile. This is strangulation, this is thrombosis. If prolonged exposure is there, they may get ulcerated and the strangulation may lead to gangrene, and other thing is fibrosis. So prolapsed piles can lead to strangulation, thrombosis, ulceration, gangrene, and fibrosis. So all these complications can occur in pile masses. So most important, of course, is profuse hemorrhage. So how do we manage? So management is, first thing, as I told you, don't dub this patient as hemorrhoids or even piles and then forget about other things. First and foremost, rule out other causes, especially colorectal carcinoma. So you have to put your finger in it and then exclude rectal carcinoma. And you have to put proctoscope and exclude lower rectum carcinomas, and then even sigmoidoscope to rule out higher above sigmoid carcinoma. So most important is exclude other causes before dubbing the patient as hemorrhoids. So of course, conservative treatment. Conservative is you have to normalize the bowel. So you have to encourage the patient to normalize his bowel movements and defecatory habits. So that they have to be disciplined about it. This is most important. Then you can again, just like Fissure in Anode, you can give stool softeners, bulking agents, all these things, laxatives you can give. And you can also give local creams So local cream consisting of some thrombophobic ointment. So the name itself is thrombophobe. And there are so many other proprietary items that contain both antiseptic, this thrombophobic, and also xylocaine for local analgesia. So many names are there. Once you become house surgeon, these people will be coming and then telling you so many things about it. Suppositories also. So for relaxation, laxative purpose, or for local action purpose. Then, of course, if these measures fail, then for first and second degree, there is what is called as Clero Therapy. You will inject submucosally either phenol in almond oil or arachis oil, 5%. So for first and second degree piles. There is a syringe, I will show you that also. Some people do banding. So ladies must be knowing about these bands, rubber bands. But these are so tiny that they need to be introduced by a gun, or called as Baron's bander. So this is also for second degree piles. Okay. So this is the syringe, Gabriel syringe, where you can inject about 3 to 5 cc of this sclerosant into the submucous region, but the injection should not be low down. It should be high above, at the level of above dentate line. Okay. So your injection should be here, not here. No, this is wrong. It should be here, high above. So then, of course, you can see the bands. There are hardly visible bands are there. You can put them here over this and then fire the gun, so that they will be after holding the pile masses, so that these bands will be fixed around the pile mass, and then thereby causing the constriction and then loss of blood supply. Thereby they become sloughed off. Okay. So that is, these are the two conservative surgeries that are available, but mainly for third and fourth degrees, what we do is hemorrhoidectomy or excision of piles. If you can remember hemorrhoidectomy, that is best. If you cannot remember, you can simply say excision of pile mass. But better term is hemorrhoidectomy. Mind the spelling here. Okay. So the main indication is third and fourth degree. That is prolapsed piles and those which are to be manually put back. So if second degree also, if the conservatively it is not cured, nowadays we do even for second degree, but mainly for third and fourth degree. So fibrosed hemorrhoids, internal-external hemorrhoids, and bleeding is to such an extent that it is causing anemia. So in this, though it is lower degree, if it is causing anemia, then you can do hemorrhoidectomy. So these are the indications. Third and fourth degree straight, second degree not cured conservatively, fibrosed hemorrhoids, internal external hemorrhoids, and bleeding causing anemia. Okay. So what is the surgery? Anesthesia is by regional anesthesia. So I think on Thursday you will be taught about regional anesthesia. and general. For children and those who are apprehensive, they may give even general anesthesia. So the position is, as I told you, lithotomy. Of course, jackknife position some people adopt. This is nothing but knee elbow with the there is no elbow elevation here. So that is jackknife. So there are many methods. One method that is very popular, which we do, is called as open method, otherwise called as Milligan-Morgan operation. Milligan-Morgan operation. So what they do is they will excise the pile masses after transfixing, and then it should appear like this. If it looks like a clover, the trouble is over. That means this is the clover. Okay, this is the shape of the clover. So if it is like this, that means the trouble is over. That means you can see that normal skin is there in between the excised pile masses. So if there is no normal skin, like a butcher, you have removed the entire skin and made it into a circular wound. That means the patient is doomed. He'll be having anal stricture or stenosis. So that is the problem with open technique. That's why at least a tongue of skin should be left between the two pile masses. The trouble here is sometimes there may be a pile mass here also, here also, here also. So multiple pile masses in addition to 3, 7, 11 o'clock. Then what you have to do is you have to dissect the pile mass away from the skin and keep the skin intact. Then only it is not going to result in stenosis. So this is Milligan-Morgan technique, where the pile masses are excised along with the skin. Okay. So closed technique is what I have shown here. So it is along with this proctoscope, it is done. So here they have removed the pile mass along with mucosa, not skin, and then they are closing it again. So that is closed technique. This is not popular in India. So in America, this is popular. Then nowadays, stapled hemorrhoidopexy with a stapling gun, PPH. So this is now popularized by the company people, that is Ethicon, which is a subsidiary of Johnson & Johnson. So they are advertising it like anything. This is a costly procedure, and it is associated with high recurrence. So those who are affordable and they want, the only advantage with stapled hemorrhoidopexy is less pain, less hospital stay. In fact, the patient can be discharged same day, evening. But long-term results are not good. So similarly, nowadays, they are thinking, just like AV fistula. You might have heard about AV fistula, where arteriovenous fistula, where there is a feeding artery to this venous engorgement. So the idea is, if you cut the feeding, naturally the venous engorgement will shrink. So with that idea, now what they are doing is hemorrhoidal dearterialization. That is, hemorrhoidal artery is ligated. So it is popularly called as HALO. So hemorrhoid artery ligation operation. So for that you need a Doppler. This is a tedious procedure The only advantage is again pain is less painful. The whole thing is patient avoids or postpones surgery because of the pain he anticipates after surgery, particularly this surgery. So that's why all these procedures have come, but they are all not without recurrence. So they will also be high recurrence in both of these procedures. Okay. Again the patient will come, again the surgeon will get some more money. That is the advantage. Only advantage of this is just like a dermatologist who can ask the patient to come regularly so that each visit they can. That's why among ladies dermatology is so popular. So you can earn more not doing anything. Keep a, now that too with the safe distance. You can now ask the patient to send WhatsApp photos. So WhatsApp treatment is going on nowadays for dermatology. So similarly, this also you can ask the patient to come repeatedly and then try to get some benefit out of it. Otherwise, the best procedure is open technique. Okay. Now, so this is as I told you as a daycare basis, or if it is open, you can discharge in 1 or 2 days. So post-operatively, you should advise warm baths and Sidge bath. So, what is this Sidge bath? Can anybody tell me what is Sidge bath? What is Sidge bath? Anybody can tell me? Yeah. 2-6. So many people have come. 4-4. 4-1-2-3. 6-3. So it is as you said in a basin. You will keep warm water, not lukewarm, to some extent warm water with an antiseptic solution. Common popular is Dettol or betadine, that is povidone iodine. But if iodine concentration is more, the patient will complain of itching. So, some warm water with some antiseptic lotion like Dettol or simple salt is enough. So, patient has to sit in that, the exposing the open wound to this solution, because it is very difficult after surgery to clean this area. So, for that purpose, warm Sidge baths are advocated. And laxatives also, because hard stool or any problem will lead to bleeding or infection. So the stool should be as liquidy as possible for few days till the wound heals. Okay. Then of course, metronidazole. Metronidazole, it acts not only as an anti-anaerobic, because anaerobic infection is very common here. We usually advocate metronidazole along with antibiotics. The other supposed action, I don't know why. If you know, you tell me, it can act as an analgesic also. So the usage of analgesics is lessened if you use metronidazole. What I think is it may be limiting the subclinical infections which will cause pain. But otherwise, I cannot know how it can reduce pain, metronidazole. In addition to its anti-anaerobic action, it is supposed to decrease the pain in these patients so that the analgesic dosage is lessened. Of course, complications are there after pile surgery, early and late. Always, whenever you are asked, you try to classify. Then you will, instead of starting to enumerate the complications, are pains, are bleedings, are like that. Instead of that, if you classify like early, late. So early is naturally pain is there. Retention of urine. This is another problem with elderly individuals, males with prostatic enlargement. You may have to, as a house surgeon, you may have to put a catheter also in these patients. But we'll try to avoid as far as possible. But if it is absolutely necessary, you should not hesitate to put a catheter into the bladder. With one episode, of course, from next day onwards, what we do is we will encourage him to pass urine by taking him to the bathroom. So, psychologically, we are prompting the patient. If you take him to bathroom, the mere sight of that, or you can open the tap also. So these are all the conservative methods before you put a catheter. Also, another method that is practiced is you will put a warm hot water bag over the hypogastrium, that is over bladder region, so that it can stimulate the passage of urine. Main problem why the patient hesitates to pass urine is pain. So if there is no pain, there is no retention. If there is pain means you have not given adequate analgesia or the patient is having some prostate problem. Another complication that is early is reactionary hemorrhage. So within 24 hours, your stitching or ligation has slipped off, and then because of the increased blood pressure. So in regional analgesia, the blood pressure will come down. Once the blood pressure becomes normal, the ligature may slip, and then with each beating, the ligature will come more distally, finally it will get out, so that there is reactionary hemorrhage. So immediately you have to again take him to theater and then ligate that again. Of course, late, after 4 or 5 days, there may be secondary hemorrhage because of infection or because of again hard stool. Anal stricture, I told you, no? So unless you leave some skin tag between tongue of skin between two wounds, there is every possibility of anal stricture and stenosis, anal fissure and incontinence. So usually what we do is we will do lateral sphincterotomy also. But if it is excess or you have damaged the sphincter, there is incontinence. So these are the problems associated with the piles. Okay. So for today, I think from next class, next Friday, I think I will discuss about, no, there is another one. Okay. So what is this thrombosed external hemorrhoid? This may be given as a 2-mark question for you. So this is nothing but a perianal hematoma. It is described as a 5-day painful self-curing lesion. If the patient wakes up after 5 days, there is no lesion there. So it will be fibrosing. So it is only external hemorrhoidal plexus will be thrombosed because of some trauma. So sudden in onset, olive-shaped mass, which is very painful, blue subcutaneous swelling at the anal margin. Okay, so if you see it, you will not forget. So I have shown you, but it is not a colorful photo. So this is thrombosed pile. Okay, but it will be, if color is there, it will be blue color. So this is often precipitated by straining, coughing, or lifting heavy weights. So if the patient comes within 48 hours, you can simply give a nick and then evacuate the clot. But if the patient doesn't come, what will happen is simply after 5 days it may resolve, or it may get infected, or it may become a cutaneous tag, which afterwards you can remove. So that is thrombosed external hemorrhoid. It is thrombosis of the external hemorrhoidal plexus. Okay. Right. In the next class, we will discuss something about anorectal abscesses, fistula in ano, and if time permits, even carcinoma. Okay. But I think we will limit to infections only in the next class. So any doubts? Hope tomorrow all of you are preparing for the seminar along with the candidates. I heard that only 2 candidates have shown the material to our registrar. All the rest 3 also should show it to the surgical registrar, so that she will edit and then modify it for better presentation. So it doesn't mean that only those 5 candidates should prepare. All of you should prepare, because this is an essay question, tomorrow's seminar topic. So all of you, please be prepared and try to ask a few questions so that you can put the candidates in some spot of bother. Okay. So that should be the spirit of all of you. Right. So if there are no further doubts or questions, we'll stop today.